Hello everyone, how are you all? Welcome to First Aid AMC Clinical. Thank you so much for joining our today's session. I hope that you guys will enjoy our session today. All right, so as you know that we are going to start our 5 months AMC Clinical exclusive course. Just it's gonna start from 21st of March. We currently are finishing our previous batch and it's just at the end of the 5 months course. So that's why we are taking the trial class, and most of you are aware that we are going to take a 2 weeks free session with you guys for the next 2 or 3 weeks to get you an idea that how we take classes. I hope that if you guys feel that this course is important for you, then you can take the decision after the 2 week session. Most of the courses usually don't allow you any live trial class, and some of them can do, but still they will never ever will get you the chance to go through the 2 week session, because just by one class you cannot say that this course is helpful for you or not. Once you know that how one topic has been totally finished, then you will get an idea that yes, this is how this course is gonna work. And that's very, very important before you enroll anywhere. Okay. First, make sure that you understand what you need. And then if any course is sufficient for your preparation, then you go for it. But don't go anywhere blindly. That's the important part. For those of you who don't know me, I am Dr. Arshan Ahmed. I will be your coordinator for the next 5 months clinical session. Okay, so I have been practicing in here in Australia, and I have got like a couple of years teaching experience, and so far never ever has got any bad review. So you guys can rely on me, or at least my experience. Now, today's session is one of the most important and one of the most notorious part for your clinical preparation. That's your psychiatry. Because most of you haven't gone through those psychiatry in your medical school or like even in your job practices. But psychiatry plays an important role in Australian health system. Like almost 30 or 40% patients that we see in GP practice or even in hospital, they are mental health patient. So it plays a very important role for your clinical exam as well, because if you know how to deal with a psychiatric patient, then you actually know how to deal with all other patients. So AMC actually wants you to be really, really good in psychiatry. But don't worry, after today's session, you will know the basic of psychiatry, which is mainly how to take a psychiatric history or psychosocial history. All right. Now, before starting the psychiatry, I'll just go through the recent AMC clinical exam changes that you really want to know before you start your preparation. I can see some of you are already from my from my ongoing course. That's good that you guys are joining this session. So for your AMC clinical exam, as you know that due to the COVID situation, it has been changed a lot. And most of you have been waiting for this time that when the AMC clinical exam will gonna start again. Okay, we'll go through those psychosocial history later on. Now, clinical exam, the pilot exam has been started last week. For those who don't know, that this is actually the starting of your AMC clinical exam this year. And according to AMC guideline, that they're going to take few pilot exam initially to see how this online exam works, because this is the first time they're taking the online exam. And that's new for you guys also, and also new for AMC, and new for everyone. But the good thing is that it should be more easier to pass than a face-to-face exam, because face-to-face exam, you need to be really, really good at like face-to-face interaction, doing physical examination over a patient. So all these are like it becomes hard when we do it over face to face rather than doing online. And in online exam, you and only there will be a simulated role player in front of you. And examiner, as I have heard that they usually don't interact with you too much, there will be an invigilator who will help you to go through each of these stations. For those of you who are new to clinical exam preparation, you guys should know that AMC clinical exam, the online one, the structure will be similar to face to face. And in here, there will be 16 stations. Out of 16 stations, two will be pilot stations, which is non-scored, and 14 stations will be a scored one. And out of those 14 stations, if you pass 10 or more than 10, then you pass the clinical exam. And trust me, this is one of the biggest achievement in your life to pass clinical exam. You have to pass the clinical exam to get a general registration in Australia. Either you go for clinical or you can also go for word-based assessment, which is really hard to get because most of the hospital usually do not provide it. So you have to really get into the clinical exam preparation. There is no way around that you can bypass this thing. So better to finish this one first rather than trying hard to pass it like after 2 3 times appearance. Okay, don't worry. First Aid AMC Clinical has a very good reputation on clinical exam preparation. We do in such a way that you guys will get all the format in a very good way and in a very concise way that it becomes very easier for a student to remember the format of a particular history. And we follow the cluster approach. If you guys have gone through our course students, they will let you know that how the cluster approach is really, really important for clinical preparation. It makes our preparation concise, smaller, but really, really hard because we know that which format we will use for particular case, and that comes into a single cluster. And for pediatrics we have one cluster and every case fall into that cluster. We just need to know how to diagnose a case and how to manage a case, which is easier if we know the cases. All right, so let's not prolong this conversation anymore. Throughout the next 5 months, whenever if you guys are joining the sessions, you will see that we will go through each of these things again and again. Okay, let's start our psychiatry session. Today's session is all about MSc, which is the mental status examination, and that's also your psychosocial history. Sorry for that. Okay, so those who are in the Facebook, are you guys able to hear me properly? If you guys got any questions, feel free to comment in your chat box in your Facebook, and I will be able to look into that and answer your queries. And those of you who are here in Zoom, you can write it in your chat box, and I always go through the chat box throughout the class. Anytime if you feel any question to ask, feel free to ask it. Okay, but usually in our class we don't allow anyone to unmute themselves because it will be really a noisy class at that time if we do that. Cool. So allow anyone, let's see. Yes, so everyone can listen properly, so we can start. Great. So first thing is, in psychiatry you need to know how to deal with the psychosocial history because most of the history will ask you psychosocial history. That means they will ask you to to take a history from a patient and go for diagnosis and differentials. Sometimes they ask you to give mental status examination to the examiner. Now, MSc is a vital part for your clinical exam psychiatry preparation because most of you will get these sort of questions. Okay, now MSc comes either in video format, so they will give you a video of a doctor and a patient talking, and you need to find out the findings out of the conversation. That's one of the format. And the other format, which is a little hard, that's you need to take history from a patient who is having schizophrenia, having mania, having depression, all of these things. Now, the most important part in a psychosocial history is to know your format very well. Tonight, we are going to go through the format and I will show you how to do the role play with any of you. And then in our next class, we will do some role plays just based on the MSc. Normally, previously, we used to take MSc class in just one session, but because MSc is very, very important for your exam preparation, I have divided into two classes. So tonight we will mainly focus on how to take the history, and the next session on 14th of March, we will do role play, just role play on the MSc. Okay. So starting your psychosocial history, remember one thing, in your AMC clinical exam, in all those 16 stations, you will get 2 minutes outside to read a particular question and 8 minutes inside your room. Now in the online exam, same thing. That means you will get 2 minutes to read and then you will start your 8 minute scored station. Now when you enter into the room, it could be a Zoom room because now it's online exam. It will be a Zoom room, not face-to-face room. So when you enter into the Zoom room, most of the time the invigilator will ask you that like some of the security questions, and also like they might check your ID, so all these things. And after that they will introduce you to the patient. So let's say that this is like uh, this is your patient Sam, you can proceed. Now when they say proceed, then you start your station. In any psychosocial history, the most important thing that you say is the confidentiality statement. Now, confidentiality statement, anywhere you will see this line that, "Hi Sam, this is Dr. X, one of the doctor here. I understand that you are having this problem. So whatever is the problem, so you can say you are having like you are having low mood for a few days. Let me assure you that whatever we are going to talk today, that's gonna be between you and me, unless it is harmful to you or others." Now, most of the candidates in the exam will use this sentence throughout their confidentiality statement in the exam. What happens that when 32 students, or like every day an examiner is looking into the video that how you are starting your confidentiality statement, and everyone is saying the same thing. So what will happen? We as a human, the examiner is also as a like is a human, right? So what will happen in his mind that he will not find it interesting, and you should sound interesting and you should sound a little exceptional to others. If you want to pass clinical exam, you have to be really exceptional, because they really filter the candidates. Okay, only the best candidates pass this exam. So you have to be one of those best. And obviously, you don't want to sound mediocre. You don't want to sound average. You should be more than average. So how we can start a conversation in a psyche case, that's very, very important. Your starting can make you pass. So always remember, greet the patient very politely. Your tone should change according to the station. The voice you use, the tone you use, the pitch of the voice that you use in your exam, that matters. No one will talk with you about these sort of things, because these are the tiny details which many people miss, and they fail the exam just because of those tiny details. Okay, now if you cannot make sure that those tiny details are all good, you might not pass the exam. Okay. Now, what we should do always, let's say you already know that this patient is like the patient came to you because wife has seen the patient trying to hang in the garage. So you already, by the look of the question, you know that this case could be a depression case, right? Because if someone is hanging, obviously they are having some sort of nervous breakdown, and most likely they are depressed. We know in our mind just by looking at the question. So you already know that you need to be very polite. Your tone should sound empathic. So say it in this way. Hi Sam, this is Dr. Arshan, one of the doctor here. I got to know from the notes that you have been trying to hang yourself today. I'm really sorry to hear that. Please don't worry. I'm here to help you. Sam, you can tell me anything that's making you really upset. I understand that this might not be a very good time for you, but I want you to know that whatever I'm going to discuss with you today is going to be confidential. Please do not feel that you are being judged. You have nothing to be embarrassed about. I am here with you unless you are ready to talk. So now you see that what's the difference? So there should be a difference between your initial statement, right? You see that how I sounded. So my voice was a little sympathetic or empathic. I tried to make sure that my patient understand that I'm really, really sorry. And I really meant it, right? Many of you, what you will be doing in your exam, because you will be very nervous and you will just, you will just say what you have memorized, okay? And it will sound very unprofessional. You have to think that this is a real patient. This is not anything simulated. This is a real patient and you want to act like a professional. Okay, so that's very important. Any problem with the hearing? You guys are hearing all right? Yeah, so those who are having trouble hearing, please check your speaker and also try to use a microphone, because microphone usually helps to understand this. And also check your Zoom audio settings. Sometimes your Zoom audio settings, um, that can be a little low. That's why sometimes you can have some trouble hearing. But I'm really loud. I can see in my mic also. So make sure that everything is all good in your part. Okay. So now you usually, yes, if it's an online exam, Dr. Tharinda, very good question. You do not need to offer water and tissue, but what I would suggest, if any patient start crying in front of you, you can just say that, well, I'm going to give you some water and tissue. Okay, so you cannot provide the patient water and tissue. You can say that I'm going to give you water and tissue. Okay, so in this way, always, like, the online exam is now more acting. You have to say everything because you don't have anything to do, but you have to say, yeah, we will still offer. That's the thing. Now, when you give your confidentiality statement in this way, patient will be happy with your approach and patient will open up. In psychiatric cases, the role player are designed in a way that if they don't like your approach, they can withhold some of the information from you. That means if they don't want to give you some important information, they can do that if they don't like your approach. And most importantly, if you don't give confidentiality statement, the role player have the permission not to give any relevant information. They can just not totally open up with you. Okay, that's totally normal because you haven't given any confidentiality statement. So you understand that this is very, very important to make sure that you give the confidentiality statement to a patient. Now, after that, you will start your psychosocial history. So, Sam, would you please tell me more about what exactly happened today? So you can always start with a open-ended question that, Sam, would you please tell me more about what exactly happened today? So Most of the depressed patient, they will not even answer this question because they usually talks in a slow monotonous speech. That means if you just ask that how is your mood these days, they will say low. Just like you ask a lot of things and they answer just single line or single word. So confidentiality statement is only in the psychiatric cases, and sometimes we use in gynae ops cases when we ask some sexual history. Okay. So start in this way. So can you please tell me more about what exactly happened today, Sam? Sam, how is your mood these days? Patient says, yeah, I'm feeling really low. How is your sleep and appetite? Okay. So start with the mood question, then ask about sleep and appetite. Now, sometimes patient can have trouble sleeping. If you get any positive findings in the sleeping, then you need to ask in detail. So do you have trouble going into sleep, or do you wake up very early in the morning? So usually trouble getting into sleep is mainly anxiety patients, and patients usually get up very early in the morning in a depressed patient. And the next question should be asked is that, have you experienced any nightmare throughout the sleep? So nightmare is a positive finding in PTSD case. So any patient having sleeping issues, we need to ask these three questions. Okay. So you ask about mood, then you ask about sleep and appetite. After sleep and appetite, the next thing we ask is the suicidal risk. Suicidal risk is a very, very important question. You cannot miss suicidal risk in a psychiatric case. So ask that any of these questions you can ask, A or B. So you can ask, do you think your life is worth living? Or you can ask, do you have any passing thoughts of harming yourself or others? If any of this comes as a yes, then we need to ask these two questions. Do you have any definite plan that how you are going to commit suicide, and any previous attempts? You can also ask, do you have any access to any weapons? But for suicidal risk, only one question is okay. So do you think your life is worth living? Or you can ask, do you have any passing thoughts of harming yourself or others? So this is the format of psychosocial history or MSc. You ask mood, sleep and appetite, then ask about suicidal risk. Then next is your hallucination and delusion question. Before asking hallucination delusion, always say that, John or Sam, I'm going to ask you some screening questions that may seem quite strange and silly to you. Is this all right with you? Because sometimes if you don't say that and you are asking that, do you see, feel, or hear things that others don't? Patient can say, what do you think? Do you think I'm a mad person? I'm a crazy person? So patient can be very like patient can confront you at that time. So just to avoid that situation, before asking hallucination delusion question, make sure you say that, John or Sam, I'm going to ask you some screening questions at the moment. This can seem very silly and quite strange to you. Is this all right with you if I ask it? Yes, doctor. So do you see, feel, or hear things that others don't? This is hallucination. So hallucination question you can just ask in one sentence, and that's in MSc. Hallucination falls under perception. Okay, so hallucination is nothing but a perceptual disturbance. So remember it because we will use it in our MSc format. After hallucination, the next question you ask is the delusion. Delusion falls under thought content in MSc. For delusion, we have like 4-5 questions to ask. So you can easily remember by this mnemonic. So RCGGP. R is for delusion of reference. C for delusion of control, delusion of guilt, delusion of grandiosity, and delusion of persecution or paranoid delusion. Okay, so for your delusion, there are mainly 5 mnemonic that we use. One is delusion of reference, delusion of control, delusion of guilt, delusion of grandiosity, and delusion of perception. Okay, after you have now in here, we have to ask this question to the patient. So you can start in this way. So do you think that someone is spying on you or trying to harm you? That's your paranoid delusion or persecutory delusion. Okay. So what we ask, do you think someone is spying on you or trying to harm you? Then do you think someone is controlling you? That's delusion of control. Do you think people are talking about you? That's delusion of reference. People with delusion of reference, they think that everyone in the street are talking about him. Okay, so they think that someone is always talking about him. That's the main thing of delusion of reference. Do you think that you are guilty? That's delusion of guilt. And do you think you have some special power? That's delusion of grandiosity. All right, so these are the 5 questions that we mainly ask for delusion. It's very important to remember that. Clear? So after you have asked these 5 questions, then the next thing that we can also ask, these are also part of delusion, is that do you think someone is inserting or withdrawing thoughts from your mind? That is for thought insertion and thought withdrawal. That is also a part of delusion. And do you think your thoughts are being broadcasted in TV, newspaper, or radio? This is known as thought broadcasting. Okay, so we have this 7 or 8 question for delusion. R is for delusion of reference. Okay, this R is for reference. So what we need to actually in here, we may not have 8, like we don't have that much time to ask all these delusion question. So whenever you will get a depression case, you will mainly try to ask this one, because in depression this is commonly present. That means delusion patient can have delusion of guilt. Sorry, depressed patient can have delusion of guilt. So do you think you are guilty? That you cannot miss in a depression case. If you think this is a psychosis case or schizophrenia case, then you should ask all these questions like, do you think someone is spying on you, controlling you? Do you think people are talking about you? All these can be positive in schizophrenia. All right. After you have done your delusion part, then the next thing is insight, judgment, and cognition. Insight, mainly we ask that, do you think that you need some medical help? Okay. People with depression, usually they have insight. So they say, yes, doctor. People with schizophrenia or mania, they don't have insight. So they will say, no, I don't need any help. So insight is very important. Then judgment. If there is a fire in this room, what will you do? A normal patient will say, I will run away. Patient with schizophrenia can say, oh my God, there is a fire in this room. What should I do? So they have concrete thinking. Okay, so they can say in this way. Or someone who is having mania and they think they are very special, they can say, I will be in this room, fire cannot touch me. Okay. So case by case, the answer will be different. After judgment, then is cognition. Cognition is mainly orientation. So oriented to the time, place, and person. So you can ask, where are you? So you can ask, all right, just hang on a second. Guys, I can see someone, if you are having trouble hearing, I don't think this is my end problem, okay? Because I can see I'm talking pretty well. My network seems good. Please check your network and also please check your audio settings, okay? Because if other can hear me, it's not my problem. All right, please do that, because if you are just asking me that sound, there is no sound and you cannot hear me, then usually it's interrupting the class. Okay, I can assure you my part is all right because others can hear me. Please look into your network and also please check your Zoom audio. In that way you can solve your issue. Okay, I'm really sorry actually but usually what happens that this psychosocial history, it should be continuous. Okay, if I can talk with you like for 15 or 20 minutes and finish the psychosocial history, you will get a really good idea about it. Okay, all right, so now you know insight, you know judgment, you know how to ask cognition. So in cognition we mainly want to ask how is the orientation of this patient. So you can ask that, can you tell me where are you at the moment? That's orientation to place. Do you know what is the date today? That's mainly time. And do you know who I am? That's person. So we usually ask orientation to time, place, and person. So three questions you can ask here for cognition. Now that's mainly your history part. So mood, sleep appetite, suicidal risk, hallucination delusion, then insight, judgment, cognition. Okay, that this part is mainly your MSc part. But if someone or if any of your station they ask you to do full psychosocial history, then you have to add all these heads, sadma, past medical history, family history, and also we'll try to rule out some organic causes. So what is HITS? HITS is very important part of psychosocial history because it includes the home situation and work situation. Now, head has a lot of thing to ask, but I don't want to like ask a lot of questions because we might end up like not be able to finish it in time. So in heads, you have home situation, you have E for employment, you have activity, diet, social support, sexual history, and stress. Okay, but don't worry on this thing because only thing in the heads that we will ask is home situation and work situation. Okay, so we will ask that, Sam, how is your home situation? Is there any stress at your home? No. Any stress at your work? No, doctor. Do you have enough support? Yes, doctor. So mainly in heads, for the rest of the psychosocial history, always remember in heads, we will ask only these three questions. Then SADMA. SADMA has also a lot of things to ask, but we only ask about smoking, alcohol, and also sometimes we can ask about medication and allergies. This D for diet. We don't need to ask about it. So I only ask that, do you smoke or drink alcohol? Any other recreational drugs? Okay, only thing that you will ask is this one. You don't need to ask anything else. Ask about any past history of mental illness. That's your past medical history. You can ask family history of mental illness. And lastly, try to rule out organic cause always. Now, there are not too much organic cause to ask about. Only three things we ask if we have time. We ask about any recent change in your weather preference. That's to rule out thyroid issue, any recent head injury, and any flu-like illness. Usually, patient with hypothyroidism, recent head injury, or sometimes very severe infection can cause some mental issues. Okay, if there is a differential diagnosis in your task, we will always rule out these differentials. All right. So just to give you the full idea about the psychosocial history, let's just go in the previous page. So in psychosocial history, you will mainly ask about confidentiality. Then you will start mood, sleep, and appetite. Then you will go for suicidal risk, hallucination, delusion. Then ask about insight, judgment, cognition. Ask about HEADS, SADMA, past medical history, family history, and then rule out organic causes. So this is the format of your psychosocial history. Anywhere you need to ask history from a psychiatric patient, we always follow the same format, anything. Okay, so make sure you remember this format and it becomes really easy. So I've got a question from Dr. Tharinda. Where does delusion of grandiosity present? So delusion of grandiosity is mainly a feature of mania, but it can be in psychotic patient also, like in schizophrenia. Okay, both. So another question from Dr. Tharinda. If the task is to do MSc and present MSc to the examiner, can we skip past medical history, family history, and organic DD? Yes, you can do. All right. If the task is to only do MSc and present MSc to the examiner, and if you are running out of time, then don't bother with HEAD, SADMA, past medical, family history. Okay. We don't need to cover that, but it gives a thorough history. If we think that we are having enough time, then it's always better to like finish your case just by asking about past medical and family history. Now, this psychosocial history will help us for the MSc as well, because MSc format and psychosocial history format is pretty much same. So by doing just one format, we can finish all the MSc cases. Okay, let's see how we are going to do that. Now, anytime in your exam, they are asking you that do MSc and present MSc to the examiner. Most of the time, this could be your task only. So MSc means mental status examination, which includes this 10 division. And it's very easy to remember. We always follow this aseptic J3R to cover all the MSc. Now remember one thing, MSc is a very sensitive case. That means that if you miss any positive findings in MSc, they can fail you, because you will just get 2, 3, or even like maximum 4 or 5 positive findings, not even that. So you cannot miss it. So that's why it's very important to stick to this aseptic J3R so that nothing you can miss. All right. Now in aseptic J3R, what are the things that we cover? A, for appearance and behavior. That means how is the appearance of the patient? And then also, how is the behavior of the patient? I will go through all of this just in the next slide. S for speech, E for emotion, which includes mood of the patient and affect. What is affect? Affect is what you observe in a patient. And mood, like when you say that, how is your mood these days? Patients say, I'm feeling really low these days. That's the mood, low. And if during your conversation, if you see actually this patient's mood is low, that means patient's mood is congruent with the affect that you have observed. Okay, so always we use affect and mood in here. So what is mood? What patient says to you. And what is affect? What you observe during your conversation. Then P for perception, which is your hallucination. Thought form. Thought form is normally whatever the patient talking, does it actually mean something? Or whatever they are saying, all are rubbish. All are like, it doesn't make any sense. So that will be included in your thought form. A normal person's thought form is usually linear. So if a psychiatric patient can have a linear thought form, if whatever you are asking to the patient, they are just answering you back. And spontaneously, they are not like talking any nonsense thing. We will go into detail about it. After thought form, another T is for thought content. Thought content is your delusion. And then you have I, C, and J, which is your insight, cognition, and judgment. And lastly, we follow 3R. So usually you will finish with 3R, which is your risk, rapport, and reliability. Risk will include that if this patient is a high risk patient or not. Rapport means that if you as an examiner or if you as a doctor able to make a good relation with the patient. And reliability means that how much reliable this history seems to you. Okay, so let's move on to the detail about this aseptic J3R. Up to this, do you guys understand what I am talking about? Any questions so far? I will go a little slow today just to make sure that you understand. Once you can adapt with me, then I will go fast. This is my style. Usually I start slowly and then after a few classes, I will be a little faster. Okay, because you need to adapt with my style. Great. Okay. Now let's start with our MSc. So when you present MSc to the examiner, you have to follow this format. Always what you can do, because this is an online exam now, and they provide you a, like you can keep a blank paper in front of you and you can write whatever you want, but not in the 2 minute initial reading time. When you enter into the Zoom room for the 8 minute, you can write whatever you want, but do not try to write a lot of things because it will just waste a lot of time. But for MSc, I would obviously say that always when you are starting your MSc, write aseptic J3R in the paper, and whatever positive points you find from the patient, just write it in front of the aseptic J3R. In this way, you will not miss anything important. Okay, otherwise there is a high chance that you will miss something. All right, so start in this way. So let's say that we have already taken the mental status examination history, because in here the history will be same. So you will start with the confidentiality, you will ask about mood, sleep, appetite, all those questions you will ask. And then you will finish your history, and then you need to give the mental status examination finding to the examiner. So you will thank your patient and say that, please excuse me for a moment. I'm going to talk with my examiner and I will come back to you. So say that, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35 years old doctor found by his partner trying to hang himself in the garage. So the case we have been discussing is that there is a vet doctor who was operating on a cat, and suddenly during the surgery, the cat died on the table. And now the vet doctor, having a severe depression with delusion of guilt, that he actually killed the cat. Okay, this is a famous vet case. So we will just follow this one for our discussion. Okay, so the brief introduction, whatever the patient presents to you, you will say here. So in here, a 35-year-old doctor found by his partner trying to hang himself in the garage. Now start with the appearance and behavior. So in appearance and behavior, it exactly what you can see in a patient when you are talking. So first thing you look is that how is the dressing? Is the dressing appropriate to the weather or not? So like if it's a winter season and patient coming to you with just a short sleeve shirt and a short pant, that means patient's dressing is not appropriate to the weather. Okay, so this is how we say that if the patient's dress appropriate to the weather or not. So first thing you say that, is he dressed appropriate to the weather? Talk, say that if this patient well groomed or unkempt. The next thing you talk about that if he is a cooperative patient or non-cooperative. Very, very important thing to say is that if the patient maintaining eye contact or not. And the fifth number is there any abnormal behavior? So it could be abnormal body movement, it could be abnormal body posture, okay, or it could be just an abnormal behavior that you have observed. What are the abnormal body movement or posture we can observe? In depression patient can actually stoop forward, and you can say patient was having a stooped posture throughout the conversation. Anxious or anxiety patients can have frequent fidgeting of their hand. Mania patient will be very restless, agitated, and they will even sometimes run in the room. Okay, mania patient is really hard to control. And sometimes you can see that in mainly in a schizophrenia patient, they will seem very distracted, and you can see that they are responding to some internal or unseen stimuli. Like they can pretend that they are looking into the ceiling and they're actually looking into someone, or they can pretend that they can see someone in the room, or they can hear someone in the room. So whatever abnormal behavior you observe, you have to always say in your appearance and behavior. Remember, in MSc this is one of the most important finding. You cannot miss what which the patient showing you. If a patient is looking at the ceiling and responding to some unseen stimuli, you have to say it. Okay, so it's very important. So if I start here, I will say, according to the appearance and behavior, my patient is dressed appropriate to the weather, he is well groomed, he was cooperative throughout the station, but he was not maintaining eye contact, he was sitting in a stooped posture. Clear? So this should be your appearance and behavior. So talk about dressing, talk about well-groomed, cooperation or not, and maintaining eye contact or not, or is there any abnormal body movement or posture? The next thing is your speech. Now, in the speech, you have to notice that how is the speech of the patient. If it is normal, so you will just say his speech seems to be normal in rate, volume, and tone. So always we use these three things to describe someone's speech. So rate, volume, and tone. So sometimes people with mania can have a rapid and pressured speech, but sometimes in depression patient, you can get a slow monotonous speech. Like just you ask how you are feeling today. I'm feeling low. Just one word, low, and very slowly. That's very common in depression patients, slow, monotonous. And in mania patient, you will see that they are very talkative and they are very talking very loudly. So you will say that there is a rapid pressured speech. Okay, so his speech is normal in rate, volume, and tone. That's one of the finding. If you get a slow monotonous, then say slow monotonous. And if you find rapid pressure, then say you found rapid pressure speech. In MSc presentation, always better to say some negative finding as well. Like you can say his speech is normal in rate, volume, and tone, but there was no slow monotonous or rapid pressured speech. So it's good because then examiner will know that what you have been looking for. Okay, so that's very important. In psychosis patient, you can get disorganized speech. In depression patient, you can also say patient has been like patient was taking multiple pauses in between the questions. So they will always take a like a long pause just to give your answer. Okay, so always say that you can always say that patient was taking a long pause in between each of the questions. But main thing you have to say that if the speech is normal in rate, volume, and tone, or is it slow monotonous, or is it rapid or pressured. After speech, the next thing you talk about is the emotion. In emotion, you talk about mood and affect. So if you ask, how is your mood these days? Patient say low. You will say, according to the patient, his mood is low. And now you will say, and the affect that I have observed is also congruent with his mood. Okay, so that means that if the patient say that he is feeling low, and you can observe during a conversation that patient is actually low, then you can say affect is congruent. Sometimes what can happen in psychosis patient will say their mood is okay, but you will see very disturbed affect. Okay, mainly in psychosis cases, we can say that according to my patient, his mood is okay, but the affect that I have observed is disturbed and it is not congruent with his mood. Okay, so in this way, we talk about emotion. The next thing is perception. So if you get any perception positive, like any hallucination positive, then say in terms of perception, my patient is having auditory hallucination, but there is no visual or tactile hallucination. Okay, so auditory hallucination, you know that if someone is hearing someone, or if your patient is hearing someone that you cannot hear, that's auditory. If patient is seeing someone which you cannot see, that's visual. Or if patient is feeling something is in something he is like crawling in his body, that is your tactile hallucination. After perception, the next thing that you talk about is thought form. In thought form, a normal person usually have a linear thought form, which means that whatever question you are asking, patient answering appropriately. That's your linear thought form. Now, what are the other abnormal thought form? Patient can have loosening of associations. Patient can have tangentiality, circumstantiality. patient can have flight of ideas. Now, there is a very important thing many candidates usually miss, that what is flight of ideas and what is loosening of association. Okay, and what is tangentiality and circumstantiality? First, tangentiality and circumstantiality. Tangentiality means that you asked your patient a question, like you asked that, what's your, like, what have you been doing in the morning today? Patients say, oh, I was just cooking, and yeah, then cooking is good. Movie was really nice to see. Oh, the fish was really, really delicious. So what I'm doing, I'm just having a very disorganized speech, and I asked what I have been doing today. I haven't actually answered that question. So if I don't answer a question and if I just keep talking and talking, that's tangentiality. And in circumstantiality, patient will talk a lot, but they will eventually answer the question. Like, what have you been doing today in the morning? Oh, the cooking is really nice. It's delicious. The book is really good. Oh, I was just watching that movie in the morning. So I answered the question, but in a, like, after I have gone through a lot of things, then I came back. So circumstantiality is a circle. So patient eventually answer your question, but after a lot of other things to say. But in tangentiality, they will never ever answer your question. Tangentiality circumstantiality is also a part of loosening of association, which means that each of the sentence patients say to you doesn't have any association. So if I say, what have you been doing in the morning? I'm saying, oh, the cooking was really nice. The fish was really good. The movie was very bad. I went to the shopping mall, but that was really far from my home. Now, what I'm doing, each of the sentence I am talking is not related to the previous statement. Okay? So if there is no association of, of my conversation, that means that I am having loosening of associations. But in case of flight of ideas, patient again will have some disorganized speech, but each of the sentence patient is talking has a little association. Okay, so let's go through a little example of those. If you look at here, this is an example of flight of ideas. Flight of ideas is characterized by rapid shift in the conversation topics. So I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So each of the sentence I am talking has some association, but I'm just jumping from one topic to another. That's flight of ideas. And that is very commonly found in mania patient. Again, if you look at here, my father sent me here. He dropped me in a car. The car is yellow in color. Yellow color looks good on me. So you understand what I'm trying to say, that there is a little association. But in case of loosening of association, see, I went to the market. I should read that book. It's a lovely evening. I feel like having a chocolate. So can you find any association? No. So there will be no association in my conversation. And that's a part of schizophrenia patient. But most of the schizophrenia patient will not have these things in the exam, because in exam they need you to provide a history. If they're just talking nonsense, then it's very hard for you to get anything from the patient. So most of the schizophrenia patient in the exam will have a linear thought form, which means they will give your answers, or they will answer your questions correctly. Okay, but you need to say that the thought form is linear, but there was no loosening of association, no tangentiality, circumstantiality, or no flight of ideas. Okay, that's your thought form. The next thing is the thought content. Thought content is nothing but the delusion. So whatever delusion you will find positive, you have to say that in terms of thought content, my patient is having delusion of reference and delusion of control. Okay, whatever positive finding you will get, you will say here. Sometimes you can get obsessive compulsive disorder. These obsessional thoughts also fall under thought content. Okay. Yes, Dr. Tharinda, very good question. So, could hypochondriasis be an example of overvalued idea? Yes. Overvalued ideas are mainly your anorexia nervosa, bulimia nervosa, body dysmorphic disorder. You can also keep hypochondriasis in overvalued ideas, but overvalued ideas mainly like if someone thinks excessively, like I'm totally perfect in my body weight and shape, but anorexia nervosa or bulimia nervosa patient will have a problem with their thought that they will think no, they are overweight and they need to do a lot of exercise or they need to induce vomiting or using laxatives to make sure they are physically perfect. So that's overvalued ideas. Never seen anything in the MSc comes from overvalued ideas, but delusional and obsession comes very frequently in the exam. After thought content, then it's easy. There is only four things to finish: cognition, insight, and judgment. So if insight is poor, say insight poor. If insight is okay, then say insight is normal. Cognition, is your patient oriented to time, place, and person or not? Most of the patient will be oriented to time, place, and person. And judgment, if it is poor, say judgment is poor, otherwise normal. So that's your insight, cognition, and judgment. And lastly, finish with 3R. 3R should be done if you want to finish your MSc. So first is the risk of the patient. Now, risk of a patient can be high risk or patient can be mild to moderate risk. Any patient having active suicidal or homicidal ideation, they are high risk patient. Any patient having active hallucination or active delusion or having poor insight judgment, they are high risk patient. Okay. If none of these are there, then they are mild risk or moderate risk. So what I have said, if your patient having active hallucination or delusion, you have to say, my patient is high risk because he is having active hallucination and delusion. Rapport, if your patient was answering all your questions appropriately and spontaneously, then you can say you were able to maintain a good rapport with the patient. Sometimes it will be very hard to maintain a good rapport in a mania patient. Then reliability, if the history given to you was reliable or not. Tricky thing in here is that depression patient or OCD patients, their history is reliable because they have insight. But any psychotic patient or mania patient, their history is not reliable. So you need to always take a collateral history from the patient or from not the patient, from their family members or neighbor or like whoever patient stays with. If the police brought the patient from the street, then you need to take a collateral history from the police. Okay. So any schizophrenic patient, you have to say that the history given by the patient was not reliable. So I would like to take a collateral history from the family member. Have you guys understood what MSc is and how to present MSc? Now I will show you one thing. Let's say that I'm doing a vet case. In vet case means that the patient is actually having no hallucination but delusion of guilt, and patient was suicidal, and patient was very severely depressed. So you will say, dear examiner, I would like to present the mental status examination of my patient Mike, a 35-year-old vet doctor found by his partner trying to hang himself in the garage. According to his appearance and behavior, he was dressed appropriate to the weather. He was well groomed and cooperative, but he was not maintaining any eye contact throughout my conversation. He was also showing a stooped posture throughout the conversation. His speech was slow and monotonous, but there was no rapid pressured speech or disorganized speech. According to the patient, his mood is low, and the effect that I have observed is congruent with his mood. He, in terms of perception, he doesn't have any hallucination. His thought form is linear. There was no loosening of association or flight of ideas. In terms of thought content, he has delusion of guilt because he thinks that he has killed the cat. But there was no other delusion of reference, persecution, or delusion of grandiosity. His cognition, insight, and judgment was normal. He is a very high risk patient because he is having active suicidal thought. I was able to maintain a good rapport with my patient, and the history that was given by him was reliable. Thank you. If MSc is your task, you don't need to give diagnosis. You can just finish there. Okay. Now see that in here there was not much positive finding. Only positive finding that patient was not maintaining eye contact. Then patient mood was low. Patient having suicidal risk and delusion of guilt. Just these four. And if you miss this, any of this, you can fail. These are key steps. There is no critical error in your exam anymore, but there are key steps and there are some specific domains that you need to pass. So key steps are like, these are the positive finding. This could be one of the key steps. Clear, guys? Any questions so far? So this is how you are going to do the MSc. Now, after the break, we'll take a 10-minute break now. After the break, we will do some cases. Okay, and I will also show you how to do role plays actually. And in the next class, we will do role play on all the MSc cases that is important for your exam. All right, so see you in 10 minutes time. Thank you. All right, everyone. So let's start again. Just give me 1 second. I'll just see that how the Facebook people are doing. Dr. Helen, so is feeling of guilt a symptom of depression or delusion? Now, it totally depends. If a patient feels like like this patient, he feels that he killed the cat. So if your guilty feeling is in an extent that interferes with your daily life, and even after understanding the patient or even after informing the patient that you haven't killed the cat, patient still believes so, that's a part of delusion. Now, depression patient can have delusion of guilt. Dr. Ruhi, very good question. So, what is the difference between tangentiality and loosening of association? Honestly speaking, there is not much difference. Both are pretty much same, but normally we don't use the term tangentiality, circumstantiality unless patient having loosening of association. So, usually tangentiality and circumstantiality is a subtype of loosening of association. Okay, so you can just use one thing, like you can say patient doesn't have any loosening of association, that's all good. Or you can also say patient doesn't have any tangentiality, circumstantiality. Okay, so now we start with some of the cages. So this one, a vet dog brought by his wife as he was trying to hang himself in the rope since a cat was died during a surgery. We just did this case, right? So if you see in here, these are the positive points. Appearance, patient well dressed, no eye contact, was gloomy and was having this stooped posture. Patient having low mood, no sleep at night, speech was monotonous and taking pauses in between, having high suicidal intention, and he believes that he is guilty about killing the cat. No hallucination. Now, in this case, in severe depression patient who actually suicidal, they can lose their insight also. Okay, so if they think that they don't want any medical help, then they don't have any insight. They can also have poor judgment in case of severe depression patient. And cognition is most of the time okay. So that case we already discussed. Next case, you are a HMO in the ED of a major hospital about to see a 28 years old man who had been brought to you by the police from the street. He is a schizophrenic patient on antipsychotics and he doesn't take his medication regularly. And he admits taking ice at times. Okay, so he's having this illicit drug abuse or recreational drug abuse. He already is a diagnosed case of schizophrenia, but he doesn't take his medication. And he was brought by the police from the street. You need to take further history from him, present MSc to the examiner with the risk assessment, and tell management to the examiner. Most of the time, the task will never ever be this much larger. Most of the time, the task is up to this. But we need to know how to do a risk assessment and what could be the management. Management is always same. We will discuss that with you today. So if we go through this case, you will understand how the MSc cases can appear in your exam also. So if you say, hi, John, it's very nice to meet you. I'm Dr. Arshan, one of the doctor here. How everything is going on, John? I can see police has brought you here. Do you know why exactly? Patient will say, I don't know. I was just roaming around the street and suddenly this stupid police just brought me here. I'm totally fine. I don't know why this is occurring. The police must dislike me a lot. So always say, whatever patient say, Say, ah, that must be very stressful for you, John. Well, John, I'm going to ask you a few questions, but I want you to know that these questions and whatever you answer today are going to be confidential between you and me. I want you to know that you can be frank with me. You don't need to hide anything to me. And there is nothing here that you need to be judged or embarrassed about. I'm not here to blame you. You can be frank with me for anything that's going on. I'm here to help you. So, John, tell me more about your mood. How's your mood these days? Yes, it's okay, doctor. Anytime do you really feel very low or high? Now, why I have added this question in here, because you need to say some differential diagnosis. And you already know that this case is most likely a schizophrenia case. Sometimes, if you differential diagnosis task, you may need to ask this question like, do you really, anytime do you feel really low or high? Because in schizoaffective disorder, patient can have schizophrenia and patient can have depression or mania. So just to rule out that, you can ask, do you feel really low or high at any time? Patient says no. How about your sleep and appetite? Okay. And do you feel that your life is worth living? Yes, doctor. Have you ever thought of harming yourself or others? No. Why I would do that? I am messenger of God, and God is asking me to do good to everybody. Now you know. Now you have got your first clue that this patient is a psychotic patient, and patient think that he is a messenger of God, right? So if someone feel that they are messenger of God, that's delusion of grandiosity. So if someone say that, oh, I'm having a very special power that I can read someone's mind, so these are all special power which will fall under delusion of grandiosity. So you should always, when you are asking these questions, try to at least write this finding, that delusion of grandiosity, so that you can say it to the examiner when you are presenting the MSc. Now, next, just follow this prompt. Say that, well, that's very good that you think that you are the messenger of God. John, can you hear God? Yes, I can hear. Always try to find out the duration, because duration can give you the diagnosis, right? Because schizophrenia only can be diagnosed if these features are there for more than 6 months. If it is less than 6 months and in between 1 month to 6 months, then it will be schizophreniform disorder. So that's why the duration of symptom is very important. So ask how long this is going on. I don't know. If they don't know, then don't bother. Have you got or do you get any specific command from your God? Anytime if you get hallucination, like auditory hallucination, if positive, try to find out, is there any commanding hallucination? Some of the cases you can find out that, like, patient is hearing someone and they are commanding to kill someone. So this command hallucination is very important to find out. So, John, do you hear God? Yes. How long this is going on? I don't know. Does your God give you any specific command? No, doctor, just to do good. Okay, that's perfect. Any other strange thing you hear apart from God? No. Do you see your God? No. So what you have done, you try to rule out visual hallucination. Okay. So this part is very important, because you found a positive finding. You are just going to the detail of it. Okay. After you have done your hallucination question, then you ask about the delusion. So in here, try to ask most of the relevant delusion question, because this is a schizophrenia case. So do you think someone is trying to harm you or is spying on you? No, but all other people are jealous of me. If in the exam someone or your role player says that people are jealous of me, this falls under the delusion of persecution. Or you can also say delusion of jealousy. But normally, this will fall under delusion of persecution. So you can ask, why do you think people are jealous of you? Because I am the messenger of God, doctor. Okay. Then very quickly, just ask all other delusion questions. So do you think that someone is trying to control you? Do you think people are talking about you? Do you think someone is trying to take the thoughts out of your mind? Do you think your thoughts are being broadcasted to the TV newspaper? So just quickly ask some of the delusional questions. And then ask about insight. Do you believe that you need any professional or medical help? They will say no. Do you know where are you at the moment? Do you know who I am? And do you know what is the date today? That's the part of cognition. And what you are going to do if there is a fire in this room. Patient will say nothing, God will save me. So you can see the judgment is poor here also. Now in here, if if management is a task or differential diagnosis is a task, you might need to go for a like a very quick heads, SADMA, past medical history, family history, and organic history. Okay, it's very quickly. Otherwise, if just presenting MSc, then don't bother with these questions. So what you will say? You will say, doctor, I would like to present the mental state examination of my patient John, a 28-year-old gentleman brought by police from the street. The reason was not known. Or brought by police from the street because he was roaming alone in the street. In terms of appearance and behavior, he is not appropriately dressed according to the weather. He is unkempt and not well groomed. He was not very cooperative with me, but he was maintaining eye contact throughout the conversation. His body posture was okay, but during my conversation, he seems to be a little distracted and responding to some unseen stimuli. If you get this finding, then only say. Otherwise, don't say anything. Next, after appearance is the speech. The rate, volume, and tone of his speech is normal. There was no loosening of association or flight of ideas. Mood, according to him, is okay, but the affect that I have observed is disturbed, which is not congruent with his mood. Okay. Then, in terms of perception, he is having auditory hallucination because he thinks that he can hear God, but there was no common hallucination or visual hallucinations. His thought form is linear. Okay, you can say thought form linear, and there was no sorry in the speech it will not include loosening of association or flight of ideas. In the speech you can only say disorganized speech or rapid pressured speech. Okay. After perception, then your thought form. In your thought form, you will say thought form is linear. There is no loosening of association or flight of ideas. Clear? After your thought form, then your thought content. In regards to the thought content, he is having delusion of grandiosity because he thinks he is a messenger of God, and also having paranoid delusion because he thinks that other people are jealous of him. There was no delusion of reference. There was no delusion of control, no thought insertion, withdrawal, or broadcasting. He is oriented to time, place, and person. His insight and judgment is poor. Okay. Then 3R. He is high risk because he is having active hallucination and delusion. If you are able to maintain a good rapport, then say, I was able to maintain a good rapport with him, and the history was not reliable, so I would like to take a collateral history from the police. So that's your MSc presentation. Now, if risk assessment is a task, most of the time it doesn't come as a task. But if it comes, then in the risk assessment, there is actually a format to do that, but that's known as sad persons. Sad persons is not needed to give your risk assessment because you will not get that much time in the exam. Always remember, in a risk assessment, what are the main thing that you cannot miss? In risk assessment, you have to talk about if this patient having any suicidal ideation. You need to talk about if this patient having any active hallucination or delusion. The next thing is how is the insight and how is the judgment. Next is support. Does this patient lives alone or does he have any family support? So someone doesn't have any support is high risk also. And also you need to see that if this patient having any recreational drug abuse like alcohol or ice or croup, anything. So any recreational drug abuse. So these are the main part that you need to talk about. So is this patient having any suicidal ideation, any active hallucination delusion, any poor insight or poor judgment? Does this patient have any support at home, or does he live alone? Does he live in the street, or does he have any history of recreational or illicit drug abuse? If you can just talk about these 5 points, then your risk assessment should be all good. So in here, if you look at here, the risk assessment that I have written, that he is medium to, not medium, usually you will say moderate to high. So he is at moderate to high risk because at the moment he is having active relapse of schizophrenia. So you can say he is having relapse of schizophrenia with active hallucination and delusion. On the top of that, he is not compliant with his medication. He has no insight and judgment. And he also abuses illicit drugs. He doesn't have any support and he's living in the street alone. Okay, so these are the main thing that you can talk about in the risk assessment. The next is management. Management in psychosocial history usually doesn't come in the exam, but if it comes, divide it into short term and long term management. Short term is what is the immediate management that you are going to do for this patient. Now, patient can come to your GP setting or patient can be in the hospital setting. Depending on the setting, your immediate management will be a little different. Now, many of you don't work in Australia, so it might be a little tricky for you. But remember one thing, in GP setting, you cannot treat any active hallucination, delusion, or suicidal patient. That means every high risk patient should go to the hospital. So if you get someone like that in your GP setting, what you need to do? So you need to call the acute care team. Okay. Now, acute care team usually will assess the patient. The acute care team, what they will do, they cannot assess the patient by coming to your GP setting. They will assess over phone. So they will talk with you, they will talk with the patient, and after talking with both of you and the patient, they will find out that if this patient needs to go to a hospital or not. So you as a GP, you involve the acute care team. Acute care team will talk with you and the patient. So it's the same like crisis assessment team and acute mental health team. So these are all same. You can also say crisis assessment team. You can say acute mental health team. So any of it you can use. They are pretty much same people. Okay. So you can say that in terms of immediate management, this patient needs to be admitted in the hospital. Okay. So what I'm going to do now, I'm going to call the crisis assessment team. They are going to review the patient And then if they want these patients to send to the hospital, I'm going to send this patient to the hospital. In the hospital, he will be assessed by the mental health team. Mental health team comprises of psychiatrist, psychologist, and a mental health nurse. In the hospital, they can also do a basic blood test to make sure he doesn't have any organic causes. So that can include full blood examination, ESR C-reactive protein, kidney function and liver function test, and a thyroid function test. And if there is recreational drug abuse history, they can also do a toxicology screen of blood and urine. That means just a drug screening. CT scan of the brain is most of the time doesn't need it. Okay, so forget about it. Now it depends that if you need to say the management to the examiner, you will say in this way. If you need to say if you need to talk with the patient about the management, then you will say in other way. So if it's examiner, you will say, my patient is having active hallucination and delusion, and he's a high risk patient, and most probably he's having relapse of the schizophrenia. So in my perspective, this patient needs to go to the hospital, but before that, I would like to involve the crisis assessment team who will assess him first. After their assessment, if they want me to send him to the hospital, I will send him to the hospital. In the hospital, he will be assessed by a mental health team where psychiatrist might put him on an antipsychotic, and when he becomes a little stable, psychologist can give him CBT or cognitive behavioral therapy, and mental health nurse will assist him during his stay in the hospital. They might also do a complete organic workup, which includes all these investigations. In the long term, they might also arrange a social worker for him, and they can also inform the community mental health worker to assist him after he discharges from the hospital. Also, me as a GP, I will also regularly review him according to the psychiatrist follow-up plan. Okay, so this is actually the management. Short-term management is making sure you involve your crisis assessment team and then send the patient to the hospital, talk about this blood test. In the long term, patient needs to be discharged, but they will need a social worker and they will need a community mental health worker to assist. Okay. So that was GP setting. So, but if it is a hospital emergency setting, then you don't need to involve the crisis assessment team. You will just say that you need to admit this patient in the hospital. You will talk with your senior and also involve the acute mental health team in the hospital. Okay, and you will organize this blood test, and then also this acute mental health team will assist this patient further. Clear, guys? The management is cool. Any question on management? All right. There can be sometimes MSc video case also. We'll discuss in our role play session. Now, today, I'm going to do a role play with you guys on this question. So you are a HMO in a surgical ward, 47-year-old patient who had a surgery done for dislocated right shoulder, currently behaving oddly in the ward. He is reported to see cockroaches. He is aggressive and difficult to settle. Surgery was done 1 day ago and there was no complication. Adequate pain relief was given. Patient has a long history of alcohol intake. Non-smoker, no past significant history. Your task is to perform a psychiatric assessment, present your finding, to the examiner. Just keep in the up to this. So present your finding to the examiner. Usually they don't ask diagnosis. So forget about diagnosis and causes. We will discuss it, but for the purpose of history and MSc, we will just do up to this. Okay. So anyone of you who wants to assist me in the role play? Dr. Afrin? Okay, good. So thank you so much, guys, for so many people wants to help. That's good. We'll do in the next. So as Dr. Afrin said first, so Dr. Afrin, I'll just unmute you.
Hi.
Can you hear me?
Yeah.
Good. Thank you, Dr. Afrin. So you are one of our student. That's good that you should know this case, right?
Yeah.
Okay. So this case is actually about the cockroach. Now, what what you need to do that I will be a role player. What I can say, I will be the examinee, and you will be the role player. Okay.
Okay.
So you will, in this case, you need to be a little hard on me, and you will say that you can see a lot of cockroaches and all over the place. This place is very filthy. So just say in this way. So this and the positive finding that you will have in here is that you can see cockroaches, and also you will show that the cockroaches is crawling on you. So
Okay.
this two is your main positive finding. Okay.
Mm. Yeah.
And obviously this is a schizophrenia patient, so your insight might be poor, your judgment might be poor. So just think that what you want to do.
Okay.
Okay. So we'll just take 1 minute time just to make sure what you want to say, and I will also, in my mind, I will also think that what I want to say, and then we will start.
Yeah.
Okay. I will stop sharing this thing. Okay. Cool.
Yes.
All right. So your name is John. Okay.
Mm.
And so let's start.
Yes.
Hi, John. This is Dr. Arshan. How are you feeling today?
Yeah, I'm doctor. Doctor, I'm good, but there is cockroach in every part of the room. Wow, it's filthy.
Oh, I'm really sorry, John. I'm really sorry that you're feeling there is lots of cockroaches around you. I'm really sorry. Please
Yeah.
don't worry. I'm just going to call the cleaner at the moment. He will be right away.
Okay.
Is this all right if I just ask you a couple of questions? If we can sit here, I know that you might feel it really filthy. I'm really sorry for that. But would you mind just to sit here, and then we can talk and that what actually going on?
Okay, do it quickly.
Yeah. And please remember that whatever I'm going to discuss today is gonna be confidential.
Okay.
John, you told me that you are having, like, you can see a lot of cockroaches, right?
Yes, doctor.
Can you tell me where exactly you are seeing those?
The cockroach is in everywhere. It's on your shoulder. Oh, hit it, doctor.
Oh, yeah. Thank you so much for letting me know. I'm really sorry. There, you might be feeling really stressed. I'm just
Yeah.
calling the cleaner. Cleaner is just coming. Okay. All right.
Okay.
So do you think like the cockroaches is also crawling on you?
Yes, doctor, under my gown. Whoa.
Oh, it's like, oh, I'm really sorry. This, and do you hear any voices?
No, doctor.
Okay, thank you so much for at least answering my questions, John. John, I need to know that how exactly your mood today. Would you please tell me that how you are feeling now?
It's okay, doctor.
Okay. Anytime do you feel really high or really low?
No?
Okay. And anytime do you think that you want to harm yourself or others?
No, doctor. Why I should do that?
No, it's just a screening question, John.
Hmm.
You'll be fine. John, do you think like anyone is trying to harm you or spying on you?
No.
Okay. And do you think someone is trying to control you?
No?
Do you think that you have some special power?
No, doctor. But doctor, there is a cockroach on the table.
Oh, I'll just swipe it out. Thank you so much for letting me know, John.
Ah,
John,
okay.
do you think? Yeah, I'm sorry. The cleaner is just coming. Okay, he's very late. I know he's just coming.
Hmm.
So, John, do you think that someone is trying to insert thoughts in your mind or trying to withdraw out of your mind?
No, doctor.
Okay. And how about like you think that you need some medical help?
No. Why I should need any help?
John, these are some of the screening questions. Just we are asking, just making sure that after the surgery you are feeling all good. Okay.
Mm-hmm.
And what you will do if you think that there is a fire in this room, what you're going to do?
Where is the fire? I need to run.
Oh no, no, don't worry, John. There is no fire actually. I'm just assuming. That's fine. And
Oh,
do you know where are you exactly at the moment?
I'm in the most dirtiest place of the world.
I'm really sorry, John. It's gonna be okay. All right. And
Yeah.
do you know do you know who I am?
You are the doctor.
Good, great. You're doing really good. And how about like, do you normally drink alcohol or smoke?
Yeah, a couple of drink every day.
Okay. Any recreational drugs?
No.
All right. Thank you so much for all the information, John. I'm sure the cleaner is just coming to the room and he's going to clean all these cockroaches. I would like to talk to my examiner now.
Okay.
Okay. So, dear examiner, I would like to present the mental state examination of my patient John, who is a 57-year-old male, had a surgery, and after that he has been behaving oddly. According to the appearance and behavior, he is dressed appropriate to the weather, but he is unkempt and not well groomed. But he is maintaining eye contact with me, and there was no stooped posture, and he was a little cooperative with me, but he seems to be distracted by some cockroaches every now and then. His speech was a little pressured, but I would say it's normal in tone, volume, and rate. He described his mood as okay, and according to the affect, I think it's quite disturbed. So the affect is not congruent with the mood. In terms of perception, he's experiencing visual and tactile hallucination because he's seeing cockroaches in the room. His thought form is linear, there is no loosening of association or there is no flight of ideas. In terms of thought content, he doesn't have any thought insertion, deletion of reference, or deletion of control, no thought withdrawal as well. He denies any deletion of persecution as well. His insight and judgment is poor and he is oriented to time and place. I was able to maintain a good rapport with the patient. In terms of risk assessment, he is high risk because he is having active hallucination and his history seems to be unreliable. So I would like to look into his past medical history, surgical notes, and if there is any family member available, I would also like to talk with him. Thank you. Okay, so that's actually how we should do it. Now, I might miss something, I might do something wrong, but that's okay. As long as I finish and as long as I find the positive points, that's all good. All right, guys, have you guys understood that this is exactly how we need to do the role play? And thank you so much, Dr. Afrin. You did really great. Okay. Why did I ask about alcohol, right? Because in the question, if you see here, patient has a long history of alcohol intake. Now, if I would not ask, that's fine. But it just came into my mind that I should ask that is this patient is having alcohol withdrawal or not at the moment. But it's if only MSc presentation your task, if you don't ask alcohol, that's fine. But normally what you should do, like try to wrap up your history. Just do not finish in the middle. Just with like how I wrapped it up, I just finished with the alcohol history. So try to wrap it up so that it seems that you finished something. Okay. All right. So this case is actually about like patient, the role player will be like really hard, and he will all the time he will just trying to say that there is cockroaches all over the places. But you have to be very very confident. Your tone, your voice should demonstrate that you are confident, because role player will try to make you confused, and many of you will be confused if you don't practice it a lot. Now, yeah, you need to finish this within 8 minutes. So sometimes you might need to run also. Okay, like if you miss something, that's totally fine. Yeah, it's always okay that you can say that cleaner is coming just to calm down the patient. And we don't actually totally agree with the patient or totally disagree with the patient. We'll be in the middle. We will say, oh, that must be really hard for you. There are lots of cockroaches. Okay. Now you don't disagree totally, you don't agree. Do not confront directly to a psychic patient. You need to be like in the middle where you don't say I am totally agreeing with you or disagreeing with you. In this way, patient will not be angry with you. Some of these patients can be angry. So you think there is no cockroaches? So you think I'm a mad person? Now what you will say? Then this will be like a really really hard. So be in the middle. Say that yeah, cleaner is coming. Please don't worry. Okay, just to make him calm down. If we can't finish within 8 minutes, will we be fail? Now, this is a question which even like many examiner cannot answer, because it depends that in 8 minutes what you have done. If you have like found out all the positive points and you did really good in your history, and if the examiner likes you, they can pass you even if you don't finish totally within 8 minutes. But try to finish it in 8 minutes. Mainly the positive findings you cannot miss. But again, if examiner likes you and role player also likes your approach, even sometimes if you miss some of the important thing, they can pass you. But that's totally their wish. Okay, some examiner can pass you, some examiner can fail you. No one actually can say that what exactly they will look into it. Now swiping the cockroaches, it's totally depend that how is the situation. So if patient says to you that, oh, in your shoulder there is a cockroach, so what you can do at the moment? You will just say, no, there is no cockroach. No, you'll just say, oh, that's okay, thank you so much. You can just even show to the patient that you are just like removing the cockroach. That's fine as long as you are getting the history from the patient, then it's good. But do not just say that, yeah, I can see the cockroaches also. Then it becomes like little problematic. Don't say by your mouth that you can see also. And this case, if they ask you the diagnosis, this is actually delirium tremens, or you can say it's a delirium due to alcohol withdrawal. Is this clear to everyone? So this was actually our today's MSc session. In the next class, we will do role play with you. So any of you are, feel free to come over to do the role play. Okay. So we'll do all the MSc cases with you. We'll do some video cases. We'll do some other role plays, and we'll go from there. Now, most likely, because in here, if you look at here, patient has a long history of alcohol intake. Any patient having long history of alcohol intake, because they were admitted in the hospital, they will not be able to take alcohol. So most of the time, those patients will have mainly delirium due to alcohol withdrawal, which is very, very common. Now, your differential diagnosis will include a lot of other differentials, like it could be infection, it could be hypoxia, right? It could be the medication you have given, like like opioid medication you have given. So you can say a lot of other differential diagnoses, but your provisional diagnosis will be delirium due to alcohol withdrawal. And the findings positive in this case, what are the findings positive? So you can say that patients like will have hallucination, which is the most important part here, which is your visual and tactile hallucination. Patient will have poor insight and judgment. So that's mainly the positive finding. There will not be having any delusion, and others are all good. But try not to memorize positive findings. In the exam, you can get any findings. Okay. So tactile hallucination means that when Dr. Afrin says that it's been crawling in my shoulders, that means that patient having tactile hallucination. All right. So guys, as you know that I have already given the first 2 week class schedule in your Facebook group, the First Aid AMC Clinical. Try to have a look at the dates, and the Zoom ID is also provided with the passcode or password. Try to use the Zoom ID and password for all these sessions. The first 2 week session is free for you guys, and usually our first 2 week session will finish on 7th of April. Okay, so on 7th of April, after 10th April, we will close this free session, and then the new batch will be started. But the free session will be included in your course also. So if you are joining our course, make sure you also join this free session, because this will not be repeated again. All right. And just at the end, I would like to show you the video of that how our course is going to be in the next 5 months. Okay, have a look, and if you guys have any questions that how this course is gonna be, and any question coming into your mind, you can ask me in here, because I will be your coordinator throughout these 5 months. Just give me a second. All right, so just have a just go through this video and let me know like if you guys have got any question. Thank you. First Aid AMC offers you the best available software for your preparation. You will get lifetime access to hundreds of lecture notes divided into clusters and topics. As you can see here, every notes that you need to prepare for your exam are here organized in a very specific way. You can get all the lectures according to your clusters, topics and subjects in your software. You can open any of these notes and you can read it while you are on the train, on your bus, on your car, everywhere you can get access to the software. We have also organized all the questions according to the months. So if you want to do role play with your partner, you can open one of our role play topics and then you can start preparing those topics. As you can see here, I just opened this one and you will get all the questions related to vomiting cluster one by one, and that's organized according to the month. And the lastly, which is the best, that's our recording. Just after the class, immediately you will get the recordings of each and every class in our software uploaded, and you can easily listen to the class if you miss it somehow. In a word, First Aid AMC software gives you the lifetime access to your AMC clinical preparation. All right, so that was a long video. Sorry for that. Now, do you guys have any question in your mind? So, Dr. Parla, what is the deadline to pay? Deadline is up to 10th of April. Yes, I'm the only facilitator for the moment, but the good thing is that we have been trying to open a Zoom group for all our course students. Like at the moment, like if we combine our course students, there will be hundreds and hundreds of course students from our previous batches. So what I'm planning to do is that taking all those course students into one platform, and I'm going to arrange a role play session like in a week, 2-3 times for like as long as they can do. Like every students will be there, and whenever someone are ready to do role play, they can see who is in the online and they can start doing role play. And sometimes I can monitor those that they are doing the role play, and I can help them also, or sometimes they can also do in their own time. So in this way, what will happen, there will be a like a greater platform for everyone to do the role play. So this is what I am thinking. So in that situation, someone from our course students who passed clinical exam, they can also help you. But otherwise, in all the classes, I will be with you. Okay, so I'll be the only tutor. So we have pesky courses, but at the moment we are not running it. We're just waiting for some approval. So after that, we will start our pesky courses. And yes, there will be mock test. Mainly the mock test, sometimes we have been thinking about these things to arrange like every month, because if we can do it in every month, then people will be more attentive. But what we have found out, like initially for first three months, no one actually wants to appear in exam. So usually at the end of the course, there will be mock exams, and throughout the course, we take role play session, like just a sole role play session, or after every cluster we finish. So that will be more or less like a mini mock exam. But yes, there will be mock tests. Yes, Dr. Wang, you will be able to see the recordings. Yes, few of our students are going to appear just in March also. So yeah, after their appearance, we'll be able to get more idea about the online exam. We're hoping forward to that. Don't worry, Dr. Farhana. Go through the recordings of today's session. It's already should be available in the group. And also for your understanding, remember that we are going to make a new group for the first 2 week free session. So we will ask you to join that group if you are interested in the first 2 week session. Okay. So just tonight you will get the Facebook group link for the 2 weeks free session, and all the recordings of the classes will be given there. All right, guys. So no other question. Thank you so much for joining today's class, and we hope that you guys will enjoy the session. Thank you all. Have a good night. Bye. Dr. Sharmila, yes, if you are admitting a patient, you should do the blood test by yourself. Thank you, everyone. Bye.